Dr. Ray here from Vet Triage. We are continuing through this issue of Veterinary Surgery from November 2024. Pretty cool case today. It's another case report. Three-dimensionally printed osteotomy and reaming guides for correction of a multiplanar femoral deformity stabilized with an interlocking nail in a dog. A lot going on there. Pretty cool. So the objective is to describe the use of virtual surgical planning and 3D printed surgical guides for corrective osteotomies to stabilize with an interlocking nail in a dog with a multiplanar femoral deformity. 8-year-old male neutered mixed breed dog, 44 kilograms. This dog had this study comes out of the University of Florida vet school. This dog had a right grade 3 lateral patellar luxation, secondary to a multiplanar femoral deformity due to suspected femoral malunion. The CT scan was obtained to obtain virtual femoral models, and then the corrective osteotomies were simulated using virtual surgical planning. The results found that post-operative femoral length, as well as frontal, sagittal, and axial plane alignment, were within 0.7 millimeters, 2.2 degrees, 0.5 degrees, and 1.6 degrees, respectively, of the virtually planned femoral model. The conclusion was that virtual surgical planning and custom osteotomy and reaming guides facilitated complex femoral corrective osteotomies and interlocking nail placement. So just before we get started here, show you what the abnormality that we're dealing with here. So the radiograph without the implant is what this dog had, almost an S-shaped curved femur with the patella laterally luxated. And then on the opposite side, you have the corrective osteotomies and the interlocking nail. So notice that femur is much straighter than it was preoperatively. Introduction. Lateral patellar luxation is associated with congenital, developmental, or traumatic abnormalities, causing impaired quadriceps function and potential lameness. Higher grades of patellar luxation are frequently associated with femoral deformities, which usually require corrective osteotomies to reduce the risk of reluxation after surgery, compared with your standard techniques like tracheoplasty and tibial tuberosity transposition. The assessment of the femoral deformities when using radiographs can be challenging, especially for multiplanar deformities with torsional abnormalities. So CT is used to allow more accurate quantification of alignment in 3D than radiographs. Distal femoral osteotomy is an effective treatment for patellar luxation and concurrent femoral deformity, particularly for frontal plane malalignment. Virtual surgical planning and three-dimensional printing of custom surgical guides have been used for distal femoral osteotomies in dogs. In another study, 3D printed distal femoral osteotomy and reduction guides helped with correction of distal femoral varus and femoral torsion within 2.3 degrees and 1.7 degrees, respectively, of the preoperative virtual plan. Deformity corrections with interlocking nails may be advantageous as they are biomechanically robust and theoretically facilitate axial alignment. Correction of distal femoral deformities with an interlocking nail has been described, but it's technically difficult, particularly with complex deformities. During interlocking nail placement, accurate bolt placement can be challenging, especially for distal bolts. 3D print guides can generate accurate distal femoral osteotomies that are stabilized with bone plates. Conventional guide designs may not be suitable for use with interlocking nails. So just to give an idea of what we're talking about here when we're looking at angular limb deformities. All right. So materials and methods. Bilateral orthogonal femoral radiographs were obtained and revealed a biapical femoral valgus deformity with recurvatum and internal torsion secondary to suspected femoral malunion. The dog had right tarsal hyperextension during standing and ambulation. The proximal and distal centers of rotation of angulation, that's known as the cora, which is the measurements that they use to plan these corrective osteotomies ahead of time. This was identified on the affected femur, and the magnitude of angulation of each cora was measured in frontal and sagittal plane using the anatomic axis of each femoral segment. Torsional alignment of each segment was determined by measuring the angulation of the axial plane between the linea aspera of each femoral segment. At the proximal cora, there was 14.8 degrees of varus, 10.3 degrees of recurvatum, 15 degrees of external torsion, and at the distal cora, 20.5 degrees of valgus, 62 degrees of procurvatum, and 50 degrees of internal rotation. And so here you can see there are three-dimensional planning with the osteotomies, making a straight femur, and then the placement of the surgical guides. And then here's kind of like the final result of what the guides would show before you place the interlocking nail. And then over here is just showing the surgeries. It's a mess. I'm not gonna go through this, and we're gonna skip a lot of the surgical details because it's not gonna mean much unless you can see videos of this. But you can see how intricate this is. This is after the correction is completed and the dog is healing after surgery. You can see that straight femur there. Again, 3D CT reconstruction. The custom osteotomy and reaming guides were used intraoperatively without any deviation from the intended virtual surgical planning. Total surgery time was 149 minutes. Postoperative femoral length was 0.7 millimeters shorter than the virtual plan, 1.2 millimeters longer than the preoperative femur. The postoperative femoral length was 20.4% shorter than the contralateral femur. The corrected femur had a 17.7 degree increase in femoral varus compared with preoperative frontal plane alignment. Compared to the contralateral and virtually planned femoral varus, the postoperative femur had 3.8 degrees and 2.2 degrees increase femoral varus, respectively. Sagittal plane alignment post-op was within 0.4 degrees of the virtual plan, with an increase in recurvatum. The corrected femur had 17.5 degree less recurvatum than the preoperative femur and 11.4 degree more recurvatum than the contralateral femur. Femoral torsion of the postoperative femur was 1.6 degrees and 2.8 degrees greater, meaning more anteversion than the virtually planned femur and contralateral femur, respectively, and 17.2 degrees less than the preoperative femur, or more normoverted. And here is the radiograph showing a couple months post-op and then 10 months post-op with complete healing and callus formation. Pretty cool. All those numbers there matter for folks who are interested in this kind of stuff. Otherwise, it's just the idea here is just to give you a sense of how how complex these repairs are when we're looking at all the different measurements. Here's a CT reconstruction again of the healed femur. All right, discussion. Correction was deemed highly accurate with postoperative femoral length and frontal sagittal and axial plane alignment within 0.7 millimeters, 2.2 degrees, 0.5 degrees, 1.6 degrees respectively of the virtually planned femoral model. Another study reported accurate distal femoral ostectomy stabilized with locking plates in 10 dogs with medial patelloluxation utilizing custom osteotomy and reduction guides. That study reported similar postoperative discrepancies in mean distal femoral varus and femoral torsion of 2.3 degrees and 1.7 degrees respectively compared with the target femoral alignment. Another study also reported accurate deformity correction utilizing custom surgical guides for antebrachial deformities with a mean radial frontal sagittal and axial angulation within 1.8 degrees, 2.5 degrees, and 3.5 degrees respectively of the virtually planned alignment. Compared to the contralateral femur, postoperative femoral varus and torsion were accurately corrected with a 3.8 degree increased varus and 2.8 degree anteversion. The affected femur, however, had 11.4 degree more recurvatum postoperatively, which is attributed to the intentional overreduction in the sagittal plane to facilitate interlocking nail placement. Sagittal plane malalignment tends to be better tolerated than malalignment in other planes. However, the overreduction of the distal femoral segment in the sagittal plane associated with use of a straight interlocking nail may contribute to extensor mechanism malalignment. Femoral shortening was not addressed as femoral lengthening is technically difficult and has a high complication. Alternatively, acute femoral length correction have been performed by utilizing open wedge osteotomies, both proximal and distal. The proximal closing wedge ostectomy performed in this case may decrease the total bone length, but straining of the femur may result in increased functional femoral length and increased tension on the quadriceps. Similarly, a shortening of the femur during femoral ostectomies improves stifle range of motion and may reduce the risk of patelloluxation. Increasing femoral length and the resultant tension of the quadriceps and hamstring muscle groups might impair stifle range of motion postoperatively and increase the risk of patelloluxation. Due to the soft tissue constraints of the quadriceps, they often shorten the femur by 5 millimeters to 1 centimeter during distal femoral ostectomies. Femoral length was 20.4% shorter in the affected postoperative femur than the contralateral. A study demonstrated that dogs can tolerate acute 20% femoral shortening and maintain full weight bearing by increasing the standing angle of the affected limb joints and decreasing the flexion angle of joints on the contralateral limb. The dog in this report had a 20% femoral length discrepancy preoperatively and postoperatively, and within 2 months post-op was sound on gait examination. Consistent with another study, the dog exhibited tarsal hyperextension post-op due to the length discrepancy between the pelvic limbs. An acute femoral length correction may have likely reduced the degree of postoperative tarsal hyperextension. An interlocking nail was placed in the medullary canal, facilitating frontal plane realignment. Femoral osteotomies are commonly stabilized utilizing plates with infrequent implant failure, but interlocking nails are biomechanically favorable to the placement of eccentrically placed plates, as interlocking nails are placed closer to the neutral axis of the femur, minimizing bending moments during weight bearing. The location of proximal and distal bolts in the femoral metaphysis allows for a single implant to bridge multiple osteotomies, whereas multiple implant constructs may have been required when you use plate fixation. Finally, distal femoral plates must be placed in close proximity to or over the stifle joint capsule, and that can lead to irritation. In the author's experience, the most common mode of failure with interlocking nails is not fatigue failure of the nail, but the proximal bolts. To verify accurate nail and bolt placement, you can use fluoroscopy and a needle arthroscope. As in the author's experience, sensation from the feeler wire can be misleading because trabecular bone can mimic the nail threads. The use of fluoroscopy and needle arthroscopy may be unnecessary, however, if guide placement is accurate and the feeler wire is used to identify the threaded nail cannulations. So a lot of information there that's really meant for folks who are interested in this very, very niche intervention, but pretty cool nonetheless to report it. So the dog is lucky here too because only one femur was abnormal. So you have the opposite normal femur to compare it to and make measurements for it. You're just trying to copy the normal limb. But some animals have bilateral abnormalities, especially if they're born with a congenital defect or a developmental defect or what have you. This looks like a dog that had a femur fracture as a puppy or whatever and never had surgery, and then it healed the best it could, but that healing incorrectly caused a problem with the kneecap luxation. What was interesting here is they did not have to do any arthrotomy. There was no stifle surgery reported, at least unless I missed it, to actually repair the patella luxation. It turns out that by fixing the femur, that indirectly and directly repaired the patella luxation. All right, guys, we'll see you in the next video. Thanks so much.